Welcome. You've joined the webinar on the interagency planning for youth with intellectual, developmental disabilities, and mental health issues. The presenters are Diane Jacobstein, myself, Linda Henderson-Smith, and Dinah Weldon. Dinah comes from is the program administrator for children, youth, and families in the Utah Department of Human Services, the Substance Abuse and Mental Health branch or division. Linda is a psychologist and director of mental health planning and policy at the Georgetown University Center for Child and Human Development. And I am a clinical psychologist and senior policy associate also with the Georgetown University Center for Child and Human Development. Much of what we're talking about today has actually been written up in an issue brief, the link for which we will give you at the end of the webinar. This report was written by the Georgetown University National Technical Assistance Center for Children's Mental Health as a subcontractor to the National Association of State Mental Health Project Directors, NASHPD, in consultation with NAD, which is an association for persons with developmental disabilities and mental health needs. And this product was developed with support from the Child and Adolescent and Family branch of SAMHSA. The work for the learning community itself was sponsored by SAMHSA through a cooperative agreement with Georgetown. I should say before I go forward that we will welcome your questions at the end. We figure that we're going to have plenty of time for questions. So, this population is really considered to be in an overlooked public health crisis. And people have asked a lot about this population. And one thing that's very clear is that comorbidity, that is with developmental disabilities and mental health needs, is super common. According to the CDC in 2012, roughly 13% of kids under 18 have a developmental disability. Of those with intellectual disabilities, roughly 30 to 50% have co-occurring mental health disorders or challenging behavior. And it's probably higher for kids with autism. The studies range somewhere in the 40 to 70% range of kids who have co-occurring mental health disorders. We know that this population is at high risk of multiple disrupted placements and long-term institutionalization. And these out-of-home placements include child welfare. A lot of these kids end up in child welfare, in developmental disability institutions, in the juvenile justice system, and in psychiatric facilities as well. And as adults, we're seeing a lot of these folks end up homeless, incarcerated, and in other kinds of institutional settings. And we know that a lot of them also, partly because of the heavy medications that they're given, end up with early illness. And in some states, we know that people, even teenagers, get stuck in emergency rooms, in jails, because their communities may not have a way to serve them. And we also know that the impact, and this is across the country, the impact on families and caregivers is huge. And it can become really all-consuming, not only because of the difficult behaviors, which sometimes include violence and aggression, but also because of the difficulties that the families encounter when they're trying to get services for their kids, and they have great difficulty trying to find help. They may be offered a lot of help, but it may not be help that's truly helpful. We know, too, that this is a very diverse group, and then mental health disorders are often overlooked or misunderstood, and so, of course, then they're not addressed. There are significant rates of co-occurring medical problems, and this is extremely important because these medical issues very often precipitate crises, and they often are not picked up. So we commonly see people get into crisis because of pain or dental pain or illness of one sort or another. And we can talk more about any of these things later on. We also know that trauma is usually not addressed in this population, but yet the rates of trauma are huge, much, much higher than the general population. These kids endure high rates of bullying and teasing and physical and sexual abuse. And we can return to that as well. Some people have asked, why is the prevalence so high? And I think there are several reasons that we can turn to. One is we know that sometimes biological vulnerabilities make people, leave people at risk for particular psychiatric disorders. We know that there are known behavior patterns associated with some genetic disorders. And this is a population for whom there can often be increased dependency, reduced ability to communicate, reduced coping skills, and as I said, a lot of trauma, a lot of isolation and social rejection. And we think that these disorders are often missed for a few reasons. One of them is that there's limited awareness on the part of professionals. Most of us had no training at all about this population in school. And we also know that symptoms may present very differently in this group. For example, if someone has reduced verbal skills, their symptoms may be presented through behavior. In fact, we have the expression, which is really important, which is all behavior is communication. We also know that sometimes the symptoms are really nonspecific, in the way that a fever, you might say, is nonspecific in medical illnesses. Well, in this kind of situation, a person may scream or cry or hit their head or do something that doesn't seem to relate to anything that you can figure out, but it turns out perhaps that the person is very ill, or the person is upset because a caregiver has left, or the person is in mourning, but the behaviors may not give an easy clue to what's going on. So it can be really confusing. And the other reason is sometimes you just get an exacerbation of old behavior. So if, for example, someone used to do a lot of spitting and that you've gotten them past that and suddenly they start spitting again, it may be some behavior, that behavior may, and its return may signal some kind of trauma or some kind of frank psychiatric illness or some other mental health concern. Also, there's a real danger here of a diagnostic overshadowing. So a lot of the mental health issues get attributed in error to the developmental disorder. So that, for example, if someone has Down syndrome and they're starting to look very withdrawn, sometimes people just focus on the Down syndrome and may miss the depression that's going on. We also know, of course, that there's inadequate screening, and we know that these kids are hidden in other populations like child welfare, as I've mentioned. And it's interesting that there are common system barriers really across the United States. Fragmented service delivery is a huge issue. We commonly see that there are large problems with access and with eligibility. Sometimes, for example, a child may be excluded from services because their IQ is too high, or they may be excluded because their IQ is too low, or they have the wrong diagnosis or something, usually having to do with funding streams. There are huge gaps in services and inflexible financing, and a lot of these issues are often layered on social disparities that are already a problem.
So knowing all of this information, we kind of decided that what we were going to do was pull all of the children's directors together in July of 2014 at the Georgetown University Training Institutes, and we did a survey about what were the top 3 issues or concerns that they had across the country when it came to serving children that have behavioral health needs. And this population was actually identified by more than 40% of the children's directors as one of their top 3 concerns in terms of how to serve this population. And then later that year in October, there was a meeting with NAD which we mentioned earlier, where this population was also discussed and addressed in full detail.
And in particular, there was concern raised about the need for support for states to do interagency planning on behalf of this population.
And so with that, what Diane and I, along with the NASHBIT and NAD, decided to do was look at how we would be able to provide the individualized support to states to begin planning in an interagency fashion, and decided that we would start a learning community.
So first, we sent out word through the children's directors that we would offer a free learning community for about 3 months to any state that would be willing to pull together a cross-agency team to work with us. And we selected 3 states, and you'll hear more about them. We offered 3 webinars and 3 one-hour coaching calls per state, and a lot of resources for strategic planning. And then we had the pleasure of making an on-site visit to each state, and in each of those visits we worked for 2 days with the team. And there was a lot of resource sharing among the participants as well. The 3 states were very different. They could not have been more different. State A had no system of care infrastructure for any population, but they were poised to roll out a statewide initiative. State B had a system of care infrastructure in some places at the local level, in some ways at the state level, but this population was not included. And there wasn't a lot of connection between the levels, or where the places where the system of care infrastructure was in place, in different pockets, really. And the 3rd state had a fully implemented system of care infrastructure for children, which included this identified population. I'm going to ask Dinah to jump in here, because one of the things that was most important about this initiative was that it was broad cross-agency participation in each of the 3 states. Dinah?
And what was interesting for us was, as we approached our partners, we recognized this was a significant gap in our system, but it was amazing as we had conversations how willing amazingly busy people were to come to the table, because we all had the same concerns, just from different perspectives. And we had a broad group that came together in Utah, but I know the other 2 states did as well, and people just really willing to share their expertise. Even when they weren't part of the public system, we had the university system, and everybody coming together to help. It was great.
So across the states, we typically had mental health involvement and leadership. We, in some states, had the Department of Developmental Disabilities. I think in all 3 states, yes. Child welfare, education, Medicaid, a key partner, early childhood, juvenile justice. The DD Council in some states had been really instrumental in providing grants and other support. We've mentioned the system of care, but particularly the expansion grants. And I think in all 3 states, we had involvement from community mental health centers and local providers. We also had involvement from the University Centers on Excellence in Developmental Disabilities, of which we are one, and the Federation of Families and other family organizations. Did I leave anything out, Dinah?
Nope.
Okay. I'm sure I did, but you get the drift. It's very broad participation. Of the 3 webinars, the first one was really on defining needs, on, as you see there, the overview, common challenges, and the impact of system barriers on children and families. And the second one was on recommendations for assessment, service array, supports, and we really highlighted 2 models, a system of care model that had absorbed this population, and the Center for Start Services model out of the University of New Hampshire, which is in, I don't know, about 15 to 20 states right now, although they're not serving children yet in all of those states. But basically highlighted those 2 models and their success in incorporating this population. And the third webinar was on financing, including cross-agency funding opportunities and resources. And we are, within the next few months, going to turn webinar number 1 and 2 into pre-recorded webinars that you can use in your own states, and webinar 3 is going to be converted into a financing issue brief, because it was just a lot of information to have on a webinar.
And it was actually very helpful for us. Because of the webinar, we had the PowerPoint, and we've continued to use that as part of our strategic planning, going back and making sure we're hitting the different points, and great resources. And so I look forward to you all having access to those.
Thanks.
There was one other, oh, you've got it. Never mind. Sorry.
Go ahead. What were you going to say?
The effective strategy checklist that we loved.
Yeah, so we gave out this checklist, which, again, we'll have a link for you at the end. This is a checklist that was prepared the year before, actually, and it was really set up to be useful to communities and to state people. And so we were thrilled when we got to Utah, and Dinah had the whole thing marked up, totally marked up, and she was working through it with her team. It can easily be used. It was intended to be used in that way.
So as we started to do our coaching calls and really started to get down to the weeds in our strategic planning, there were 3 themes that really kind of emerged as to where planning, interagency planning really needed to be done. At the policy level, looking at, Medicaid policy and financing policy to ensure that this population was covered. At the state and local infrastructure level, as well as at the services and supports level, where a lot of workforce development needed to be done, and cross-system education, so that there was a better understanding at the system level, at the services level, of how to serve this population. Some of the examples of strategies that were developed that really kind of came out and that were common. Most of these were either in 2 or all 3 of the states. One was about reviewing all of the funding streams for both the mental health system and the intellectual and developmental disability systems, and aligning them as best as possible. So looking to see if there were ways where, if mental health didn't pay for something and DD did, where they didn't then exclude one or the other, for example, because many times in mental health policy, especially when it comes to Medicaid, there's generally a exclusion for those that have a mild or moderate or severe developmental disability. And so really aligning those as best as they possibly could, as well as reviewing Medicaid policy. In one state in particular, I remember hearing the Medicaid director say, oh, well, all we really have to do is just remove 3 lines, 3 sentences where we said that these children can't be served. And so it wasn't something where they had to go back to the Center for Medicaid and Medicare Services. It was something they were able to do internally once they did the investigation about the cost, because we all know that that's what's most important. Another strategy that was actually utilized in 2 of the states was actually developing a crosswalk of the clinical eligibility requirements for all funding, because what was happening was in the development of their clinical criteria, they were indicating things that they didn't necessarily know were becoming barriers for children and families to receive the services that they needed. And so they wanted to kind of lay all of that out to see where the gaps were and what modifications needed to be changed. So other examples that came out were like the use of telehealth consultation to increase access to specialists for rural providers and families, as well as those that were in urban areas and just didn't necessarily have the capacity to serve more in person. So figuring out how telehealth would be able to be utilized to increase access was one of the major things that came up, especially in 2 of the states that had very rural populations and demographics, as well as developing at the state level a multidisciplinary team of providers and state officials to actually help develop further strategies for serving this population and figuring out really truly from the ground level what those barriers really looks like. Because sometimes at a state level, state bureaucrats and policymakers don't necessarily understand the implications that the policies had at the service level. And so being able to actually talk to and hear from pediatricians and psychologists and dentists, educators and occupational therapists and physical therapists and families was something that was going to be extremely helpful to those states to make sure that they had a quality improvement feedback loop regularly as they were pushing out policies to see what that feedback was. Other things that we thought were important that actually came out were to actually develop or modify education materials, including provider manuals, best practice guides, and family handbooks, so that families and providers and even the community at large would really know and understand this population, as well as what resources were available for the population and how to access the system. A lot of the feedback that we got in these multidisciplinary interagency collaboration was from families saying, we just don't even know where to go and what to do. We don't really know how to access the system, what services we should be asking for. And so as a result, the state really looked at how they would be able to do a better job of outreach and education around this population.
And the family voice in the process was so critical because we were looking at the state level and structures and to have their feedback to be able to bring in that perspective and for us to make sure that we were working with policies and strategies that enabled the system to change to meet their needs, as we all know, is critical. And so that made a great impact for us as well. So some of the other lessons learned was that you saw the slide where we talked about the broad agency collaboration that was necessary. Having the partners at the table representing all the different perspectives and the needs allowed us also to begin to develop language across our systems, which we tried to, moving away from that two-system concept of either they're in the developmental disability world or the mental health world, we looked at it as building a bridge to help us cross more than just the two systems, but to be able to have shared language and common views. That the values and principles of systems of care gave us a great framework and common language and concepts, but that time together with Linda and Diane was critical in helping us to build much stronger partnerships. And the leadership of the state children's directors were in the different states was helpful because we've been around for a while. We have those relationships across the systems and being able to pull people in, but also having the leadership from all the child serving divisions or agencies, how it broke out. They were there at the table saying, yes, we want to do that. They're not necessarily the ones that were going to make it all happen in terms of the specific strategies, but they were the ones that empowered to say, yes, we're going this direction. Yes, you have our authority. And then we sat around and worked out all the details of how that would happen. Some of the critical things that we really needed to look at, you've heard about, are the aligning of policies and financing and looking at our state system and funding. And that was, so in addition to policy, we looked at funding, we looked at gaps that are currently in services. Families were really good at helping us to see some of the significant gaps and some of the frustrations that they were experiencing. And then Linda and Diane brought in great knowledge in terms of best practices and looking at assessments, but also helping us look at how we can develop our workforce. I think on the mental health side there was often, and still is, and it's what we're working towards through some of our policies and strategic planning, is being able to help our workforce regardless of whether which system the kids are hitting in. We have skills to be able to step up and bridge and meet the needs of the youth and not say, oh, I don't know how. So we talked about, Diane talked about trauma in the opening, being able to help our staff know how to meet the trauma needs and the mental health needs and the IDD needs without saying, I can only do this small little piece of it, and bridging and linking to those. Then we also discovered that there were resources out there we weren't even aware of. And as we all came to the table, we could then share and cross-pollinate our ideas and resources, and that was helpful for us. The strengthening the feedback loop of being able to figure out what's working, what's not, was important, and finding ways of, we wanted to go across the systems, not just directors, not just middle managers, but a lot of what's happening locally. In Utah, we have 80% of our population lives in 20% of our state, but then we have 80% of our land that only has 20% of our population, and we needed to make sure, as I'm sure all of you experienced, that what we do in different areas we're aware of, sensitive to the local needs, and then getting feedback when things aren't working. So that was important, and we really wanted to focus on changes that were within the sphere of our influence, things that were doable. We know structurally as children's directors, we've talked to NASHBID, we've talked to SAMHSA, there are things that at their level they can do, there are things that our department can do, but we wanted things that we had control over. And so it felt when we got done with the 2-day training, or the 2-day strategic planning, that we actually had functional things we could move forward with, and that was very helpful to our state.
So one of the things I want to make sure that we highlight again really truly was the leadership at the state level from the children's mental health directors. In all 3 states, the amount of time and energy and passion that those children's directors had to really truly get people to buy in and understand that this wasn't just yet another initiative, yet another something to do, but really look at how it could be, this population could be incorporated into the work that they were already doing, because they really were the kids that they were already serving, was extremely helpful in ensuring that we were able to help them really truly come up with doable changes within a 12-month period, and were able to give them the information and the help that they needed. So after doing this learning community, we really kind of learned some things that had some implications for the field as a whole. I think the biggest thing, obviously, was that this is a population that we're already serving but not really serving, but that really needs support. So this is a population that, in general, generally gets bounced around from developmental disabilities agencies to education to mental health, and everybody is serving a little part of that family, but nobody's really looking at that child as a whole and providing the support. And so what we realize is that this is a population that really needs some focus, and at the state levels, at local levels, and at national levels. The other really big thing that came out was that it really wasn't necessarily about asking for more money. It really truly was about looking at how the money that you already had could be utilized differently for this population through policy, infrastructure, and service. In not one of the plans did we actually say there was no goal where it was that they were going to go ask for more money. It really was looking at the money that they already had, the policies that they already had, and how they could already serve this population, or how they could serve this population with what they already had. One of the other large things that I think we all know is that cross-agency data collection is important to making decisions for this, especially for this population, because they really truly do touch so many systems. We also know that it's very difficult to do. Matching cross-agency data was not something that was, could be done within a 12-month period. But for at least 2 of the states, it was put as we can't necessarily do this right now, but it's something that we need to be working on along the way to ensure that we can really truly start to track this population, look at their outcomes, look where we're really spending money on them, and look at how we would be able to modify that to serve them more in the communities, at home, getting them the in-home supports that they need, and addressing all of their needs. The collaborative work focused on this population would drastically potentially reduce states' vulnerability to legal action. I mean, this is a population who, in general, tends to do things like sit in ERs for 2-3 weeks. I know when I was a children's mental health director about 2 years ago, this was the population that caused us the most problems, mainly because we didn't have the service system and the support system set up to serve this population. When we were getting phone calls at the state from our mobile crisis teams or the emergency rooms, without a shadow of a doubt, 99% of the time, this was the population that would do that. And many times when that type of stuff happens, that's what ends up in newspapers. That's what ends up in legal aid and in other legal departments where they want to really truly do some legal action towards making sure that the state does what they're supposed to do for all of their citizens. And so if the state as a whole, working with children, working with families, working with providers, working at the local, the state level, if they actually work together, they can look at what services are really needed and really put a system in place to avoid legal action. And lastly, I think one of the greatest things that we learned and that we heard in our feedback was that actually having someone independent of the state, someone that didn't work in the state, someone that was an expert that came in, an independent facilitator to assist with the strategic planning was extremely important. Mainly, go ahead.
I just want to say absolutely. That was so critical for us. What the 2 of you brought in, not only your expertise, but your ability to allow us time to try and formulate and grow out what our biggest concerns were, where we wanted to spend our time. But then you helped us figure some very narrow strategic goals to work towards that. So I just wanted to say amen.
I would just add one thing. It's pretty clear now from having seen it work in a few places. We know that this population can be served well, and it can be done, and I think we've got some really good models now on how to pull it off. So this, again, is the issue brief that we mentioned earlier and that describes this learning community in somewhat more depth. And as you see at the top, there's a link that should take you straight to it. And this is the link for the resource document that we referenced earlier as well, which talks a lot about critical information for this population, appropriate service array, has some financing information and stuff like that. But I think you'll find it useful. And here are our emails, and we welcome your communications. We wanted to also add that next Tuesday between 1 and 2, that we're going to get the call information to you through the TA telegram. There'll be a way to call in, and I'll be fielding calls during that time. And you can also contact me at any point at the email there to schedule a consultation and technical assistance. And I'd be very happy to do that.
So we wanted to really kind of leave some time for questions from you all. There's been a couple of questions in the chat box that we're going to answer, but if you guys would like us to answer any questions, if you could just type it in the chat box, then what we can do is read the question and provide an answer for the recording. So the first question that I saw was, are there any handouts? So instead of handouts, we provided the links within the PowerPoint so that you'll be able to get to the resource documents that we spoke of.
And in addition, this PowerPoint itself will be available to you.
As will the recorded webinar. So I think I just answered Michelle Hill's question as well about a copy of the PowerPoint. So a question about, are you collaborating with the Centers for Independent Living?
I actually don't remember if we should be. I mean, the state should be collaborating with them. I don't honestly remember. And maybe Dinah, is that a factor in, is that part of your team in Utah?
I'm taking notes now, and we will be outreaching.
Thank you. Thank you for the question. It's important. I think one of the states is collaborating with them, but I'm not positive.
So there's a couple of other statements. Okay, so question. The developmental disability and behavioral health agencies in my state, even though they are both under the Department of Health and Human Services umbrella, are notoriously poor at playing nice with each other. It is really an issue of whose ox is being gored for budgetary purposes. Oh, okay. I thought there was a question in there. I'm sorry.
Well, I think there is an applied question because this is a huge issue in many places. So I think we should respond to that. So what do you do if you're in a state where the departments don't play nice with each other? What can you do to start the process?
I mean, I really think that it depends on where you are. If you are a provider, if you are a family member, if you are an advocate, or if you're actually in those agencies. And Dinah, help me if I say this wrong, but if you are a parent or a youth or a provider, having that discussion and really trying to bring that attention and that issue to your children's mental health director, to anyone at the state level that is able to really look into what's going on with that and address that would probably be my first step.
And another one, in many states, the power of the family organization has really been able to pull people to the table and to help them see that it's in their enlightened self-interest to play nicely together. Diana,
yes, I think our family organizations have been really helpful and can help be the glue bringing us together. But I also see that our tone and attitude with each other, sometimes I'll be out working with the public mental health system, and a few years ago, they'd start getting into some blaming. And I would reframe it and talk about legislative mandates and funding, and they would do the same for us. And we really worked on developing our relationships at the state level, but one of our strategic goals is to develop relationships at the local level. So as we looked at some of the planning that we wanted to do our learning collaboratives in the local communities so that they would be sitting in the same room together and developing their partnerships just as we've been developing our partnerships at the states for the last couple of years. And any opportunities that they have anything to ask, we jump and help, and vice versa. And that builds and strengthens the relationship for the next time.
So the next question is, my agency currently receives funding from NYSOMH, but not OPWDD. I'm assuming that means that you receive funding from mental health, but not DD. Are there any contacts you recommend for us to continue these conversations? So, I mean, if you're already receiving funding from OMH and you think that getting funding from DD is probably something that you need to do, I think the first thing that you begin to do is have a conversation with the person that you already have a contract with and really make them aware of the issues that you're coming into and ask them to help you make that connection with their counterpart so that you can try to make your case with the DD office.
And I would add that in your state, the Center for START Services is going live. I don't know if they're in all counties yet, but they are branching out, and they're developing programs, I believe, in every region in New York. So it's just something to be aware of. You may want to make contact with them as well. It's a Center for START Services at the University of New Hampshire. I don't think we have any written questions up here. We certainly welcome it if people would like to add some written questions, or if we don't see any. I think earlier there was also a comment that I think is important to address, there's one person who said that there will be no more behaviorists for those with DD, only mental health crisis services. And we see this in many states where there are huge restrictions on services available to this population. And I guess I would direct this question to Dinah and Linda. And what can people do if they're in a situation where there are severe restrictions? Either people can't get on waivers, or the services are really restricted, or certain diagnostic procedures that are needed are not available. The particulars are different in every jurisdiction, but we see this everywhere. Dinah?
I think that's our situation, that it's really separate systems, very limited funding. It's easier to get in the mental health door than the IDD door. It's a very restrictive waiver. And so that's why we didn't focus on, we tried to focus on things we could actually influence. Any few words you mentioned that you could take out or change, any funding things that we could tackle, developing our workforce so that they could bring their skills higher to meet that need and cover that gap without requiring us to wait the 5 years to structurally change everything going on.
And sometimes it's things that are already in place that can be harnessed. One state decided to include information about this population in some ongoing training that they were already doing in one of their systems. Maybe Linda can help me remember which system it was. But sort of to take a look at what training is already happening and then insert this information into it is a hugely effective strategy. Another thing that in addition to really working closely with the family organizations to harness the sense of urgency at the state level, I think some states have turned to the DD councils. There is a DD council in each state. And sometimes they actually have small grants that can be used for seed money to get this going. Some states have also used a particular document that it was published by the National Medicaid Office, by CMS. It's a Dear Medicaid Director's Letter about autism, and there was also some follow-up frequently asked questions document that was also very useful. And sometimes that document has been used to kind of push the situation forward. A lot of states are concerned about, I guess, about lawsuits and about having CMS perhaps raising some concerns. And so they're using the language in that document to kind of pull people to the table and to say we need to look at this together.
Mm-hmm.
And the family, Dan, I was just going to say, you mentioned the family organizations. They've really helped maintain the passion and the emphasis since you left and have made a lot of progress on and discovered curriculums and funding for being able to go out and do some of the training. It's been exciting to have that power behind this effort.
And you remind me also that in one of the states, the school system was going to take this up. They were already doing a trauma initiative in that state, and they were going to add training for teachers and for personnel in schools, and I think for family in schools as well, around this population, just basically to include it in the structure that was already in place. We have another question here from Keith. Can you mention some of the most common physical conditions that can affect IDD members? I think it says. This was briefly mentioned earlier in the presentation. Absolutely. There are many, but they include seizure disorders, which are very common as people have lower cognitive functioning, and also very common with autism. We see a lot of, with people on medications, we see young children even on huge amounts of medications, 8 medications, 6 medications, and sometimes medications that should not be used together. If this is an interest, contact me later or come to the office hours next time. I can get you some resources. But when those medications cause weight gain, obesity, diabetes, and those kinds of illnesses, and this population, not even young adulthood and into adulthood, we start to see illnesses of old age, like diabetes, heart disease, mobility problems, that probably are, in some cases, exacerbated by the medications and often exacerbated by poor diet and poor access to health promotion activities like exercise and stuff like that, which we think has a huge impact. And especially because when people are feeling crummy, they tend to have more behavioral concerns. And also, what did I leave out here? We also have, each of the genetic disorders may have known medical complications, and it's really important to know the genetic disorder. And some states are not funding that genetic testing, but it's really important because when you know the genetic disorder, you can find out what the typical behaviors are that accompany that disorder, like the behavioral phenotype. As an example, with Down syndrome, I'll just pick on that one, but because it's sort of common, but commonly have severe cardiac or mild cardiac problems. You commonly have anxiety, sometimes depression, often ADHD. That go along with it, and so it's really important to make sure that genetic tests are done when appropriate. And oddly enough, one of the most common concerns that gets people into the hospital, this is super common in adults, but you see it in kids as well, is constipation. And if someone can't tell you, what's bothering them, and they're having a lot of pain due to medications that are causing them difficulty, this often gets people into the hospital. Dental pain, because very often in some states, I don't know how many states, maybe Linda knows, but in some states, dental services are not included for people on Medicaid, which makes very little sense to me. But those are some of the things. And Keith, if you'd like more information, there is some in that second issue brief, the effective strategies checklist, but I can get you some more information if that's something that would be of interest.
So the next question is, will you be making a second webinar, Read Best Practices, available? So we are in the process of recording both Webinar 1 and Webinar 2. The goal is to have both webinars and the financing brief published by the end of June. Georgetown will be putting those out, and what we can do is just ensure that the people that would like that will have access to it. So it'll be free, it'll be on our website, and we'll be able to let you know when that is done.
And we can put it out on the TA Telegram as well. Yeah. Any other questions?
Well, if there's no more questions, we want, oh, I think I see someone typing. Hold on. Oh, so if there's no more questions, we're going to go ahead and end the webinar. We want to really thank you guys for listening to us and participating. If you guys have any questions, please feel free to email any of the three of us. And please remember that we have office hours on March 29th from 1 to 2 p.m. and the information for getting into that will be available through the TA Telegram on Monday. Okay? Well, have a great day, everybody.
Thank you so much.
Thanks.